Well, a big question that's being asked at the moment is, will the bill go ahead? And if it does, then what kind of changes will be required to get it to pass? I think that because already there's been so many changes in the National Health Service as a result of the bill and indeed the white paper, it's highly unlikely that the bill will be junked. It will be modified, is my prediction. And there are probably at least two big areas, I think, where concessions will have to be made. The first one will be on competition, and there is widespread concerns about privatisation of the National Health Service, the fact that for-profit companies might come in and start providing care and taking profits and so on. So I suspect that parts of the legislation will be watered down, in particular the role of the economic regulator in promoting competition. And I suspect and actually hope that the role of the economic regulator will be to not just promote competition as appropriate, but also promote collaboration as appropriate. And that will then allow some kind of interesting developments to happen on the provider side along the lines of integration, which I think there is a consensus around the service that integrated care is needed in order to make the efficiency gains that we need to make, in particular for older people, frail people, people with multiple chronic conditions. So I think that's one big area of concession, to have watered down competition in the bill. The second big area, I think, is the consortia themselves, the GP commissioning consortia. And there are lots of worries about the governance structure. So it may well be that concessions will have to be made to tighten up the governance, in particular representation by the local accountability to the local population will need to be changed. So that expect some changes there on who will be on the boards of these organisations, whether or not they're just primary care, whether they should involve perhaps hospital clinicians, nurses, social care, local authorities, and so on, along the lines that the Health Select Committee have suggested. So I think those are two big areas where there'll be concessions, and I suspect that then with a little bit more politics being the art of the possible, then there will be enough consensus to pass a bill that is workable and isn't just a hodgepodge of people's amendments. So I think the answer is the bill will go ahead, and then that itself will be less disruptive than a whole-scale reversal, which would be unfortunate. I think there are two main sets of issues here. The first one is the politics. There are many people who feel that they haven't been appropriately consulted, that actually they would have liked to have spent more time helping to craft the bill and the white paper before it. So there's an issue about stakeholder management that really is a political issue, which I'll leave to one side. But the second issue is that many people think that what is now necessary in the National Health Service in terms of its longer-term development and in order to achieve the efficiency savings that we need to make, could be done without any need for further legislation. So those two issues are combining to make there to be significant opposition. What we set out in our briefing is the way that we think some of those issues, particularly the second one, could be addressed. Well, I think that there are worries that an economic regulator might interpret its role as to aggressively promote competition within the provider side of the National Health Service. And we at the Trust, on looking at the evidence of the impact of competition, believe that there is a role to promote greater competition in provision of healthcare, clinical services in the National Health Service. So we're comfortable with that. But we also believe that for the NHS to make the efficiency savings it needs to concentrate far more on integrating care. Now, across the globe, economic regulators sometimes view vertical integration of services or collaboration between, say, GP services and hospital services. They view that often as being consolidation, about monopoly, which is bad. But we believe that there is a case to be made for the benefit to patients, to taxpayers from vertical integration of the type that we've described. And so therefore the economic regulator really needs to promote collaboration as well as competition, and really needs to be cited on the kind of benefits that vertical integration can produce. So those are sorts of changes that we like to see and think are appropriate. So the economic regulator should not be a straight down the line economic regulator that you see in other sectors whose job simply is to reduce consolidation. We actually believe healthcare is different, and some consolidation on the provider side is necessary. Well, there are two issues, big issues, with the National Health Service at the moment. The first one is, where is it developing? How is it evolving? And actually what we believe is that it is evolving on a similar pathway to many other developed country health systems that we see and like to compare ourselves with, for example, as seen in Holland and Germany. So there we see the same kind of aspirations about universal coverage, about giving people more choice, about more personalised care, about giving clinicians much more responsibility to manage a budget because they are responsible for resources in the National Health Service, about different ways of paying for care that might incentivise good performance and so on. So we see this kind of a development happening all across the developed world. And the bill itself actually pushes us further in that direction. But in the short run, there is a big issue, of course, which is about the economic climate. And there the NHS is having to face making efficiency savings that it has never had to make before. 4% efficiency savings at least per year. No country is having to make this level of savings. The NHS has never had to do this before. It's the most parsimonious settlement for the next 5 years that it's ever faced. So it's going to be very, very tough to allow the NHS to evolve in the way it is and should be in the light of the need to make efficiency savings. So the trick to pull here is to allow the NHS to evolve in a way that helps to deliver those efficiency savings, and not to make cuts which will push the NHS back from this natural evolution that it is taking. So that is the huge challenge. And of course, in the short term, the issue is, to what extent does the centre control the NHS in order to keep a grip on finance, to make sure it doesn't lose financial control, as it has done in the past under periods of great reform. So these are very big things, both to manage the finances, but also to manage the staff and the public, to make sure there isn't public discontent or staff action against what will inevitably be cuts. So that's really the challenge. But in the long run, the kinds of things that are in the bill, we believe, do push the NHS in the right direction. There are some gaps that need to be filled, there are some changes that need to be made, but overall it's a logical sequence. Well, the trick to pull is to make sure that there is enough grip on the system to make sure that the NHS doesn't topple over in the next 2 years. For example, to make sure that hospitals stay afloat, that waiting times don't go down the drain and lengthen, to make sure that there isn't excessive rationing and so on. So, but to make sure that that control isn't excessive, so that it simply demotivates staff towards taking the responsibilities that they need to take in the long run in order to have more innovation in the system, which is absolutely necessary. So getting that balance right is going to be very tricky. At the same time, as the heat is on with respect to the finances, both the commissioning side of the National Health Service will want to put together risk pools of money just as a kind of contingency, and also that is also likely on the provider side to make sure that there is a fund to bail out, where necessary, distressed hospitals. But those two funds may well take resources away from the front line in the short term. And that can add up to be a sizable percentage, as we are already finding out. So I think there needs to be much more transparency in the system with regard to the financing of the system, to make sure that those top slices, as we call in the trade, aren't too great, so that very little is left over for providers and commissioners, and also how they are divvied up then amongst commissioners in particular, but also providers, is also transparent, so it doesn't poison incentives in the system. And that's going to be really, really hard to manage in the short term. So it's going to be severely challenging.